So we appreciate the opportunity to come today to present. I think this is an excellent way to do it in connection with the commissioner meeting each year. I know it's very difficult for you as commissioners sometimes to get away, to be able to participate in the training. So we try to make it as convenient as possible, and we appreciate the opportunity to connect it with the commissioners meeting. So to start off, I want to just briefly do, I know most of you in this room have probably seen this before, the overview of what the state's mental health system is. So Mississippi's mental health delivery service system is made up of three components. You have state-operated programs and community services programs, and Mr. Hutchins is going to briefly review those. You have regional community mental health centers, which are in this room, and then the commissioners. And then you have other nonprofit and for-profit service organizations throughout the state. There's about 128 providers that the Department of Mental Health certifies statewide, and that does include the 11 community mental health centers. So you can see here there's three service areas that fall within the state's mental health system. In blue is what we kind of refer to as mental health. So you have the DMH operated programs, you have the 11 community mental health centers, and the other DMH certified providers. The kind of yellow gold is intellectual and developmental disabilities, which is also part of the state's mental health system. And those are provided through DMH regional programs, the mental health centers, and other providers as well. And then the kind of orange rust color is substance use disorder. And you have the 11 community mental health centers. We have 2 chemical dependency units that the state operates, and then you have DMH certified providers as well. So this next slide gives you kind of an overview of what it looks like across the nation. So in Mississippi, you just saw that previous slide where you had substance use, IDD, and mental health. All 3 components fall under the Department of Mental Health in the state of Mississippi. And this might be a little difficult to read, and we'll share these slides with you as well. And also, just to let you know, the training is being recorded for commissioners who weren't able to attend today to where they can participate virtually. So we'll get you these slides. But you can see the color that Mississippi is, kind of that yellowish color. Those are the states that have mental health, substance use disorder, and IDD. All 3 combined within their Department of Mental Health. The darker green are states where their Department of Mental Health only has mental health. Your lighter shade of green are states where mental health and substance use disorder is combined into one agency. Your blue, which there's one, is mental health and IDD only combined. But you can see in Mississippi, the Department of Mental Health is responsible for adults, children, and youth for mental health, IDD, and prevention and treatment for substance use disorders. So as far as the community mental health centers, there are now 11 community mental health center regions. Stephanie, you might have to hit a couple more times to get the bullets. Sorry, we don't have a clicker. So there's 11 community mental health center regions. On February 1st, 2023, counties within Region 1's catchment area began receiving services through Region 6. On July 1st, 2023, counties within the former Region 11 area began receiving services through Region 12 and 15. So you can see that two different community mental health center former regions dissolved this year, and those counties are now receiving services through another community mental health center region. When you look at the map, sometimes it's confusing because you see all the way to numbers 15, but there's no 13, there's no 5. This is where consolidations have happened through the years. So with the community mental health centers, the state established community mental health centers, which work in conjunction with and are subject to oversight by the state. But as you know, they are regional entities. They are local mental health authorities that are part of county government. But each community mental health center is the entity in that region to be responsible for preventing unnecessary hospitalizations. And that's going to be a lot of what we talk about today, is some of the services and where we're at with a lot of those services over the last year. and how the community mental health centers have played such a role in that. But you've got the responsibility of identifying individuals with serious mental illness in need of mental health services. You have the screening of individuals. This is the pre-evaluation screening to determine if someone needs a commitment order or not. Coordinating the health care for individuals with serious mental illness, and then also diverting individuals from unnecessary hospitalizations through the provision of services. And this has been a heavy emphasis and a major role of the community mental health centers, especially over the last several years. To just briefly touch on spending, I wanted you to see how the change has occurred. This compares 2012 to 2023. So you can see that in 2012, 57% of the budget was spent on institutional care and 43% on community services. In 10, 11 years, you can see that shift has changed to 59% goes towards community services and 41% towards institutional care. So the funding that the Department of Mental Health receives that goes towards the community mental health centers, DMH administers about 650 grants each year. It's a large role of what central office for the Department of Mental Health does. That's right at about $108 million. Now this is based on FY23, so with ARPA funding for FY24, that amount increases and so will the number of grants. But you can see in FY23, right at about $85.5 million or 79% of the funding is provided to the community mental health centers for services and supports. And the reason for that is 2 or 3 slides before when we had those bullets of what that responsibility is. That responsibility of diverting individuals, screening individuals, providing that care, being that local mental health authority. That is why 79% of the grant funds do go towards the community mental health centers. $43.6 million in FY23 was allocated for specific key services that were in the remedial order. And those services all revolve around preventing unnecessary institutionalizations. And we'll talk about those in a few minutes. In FY24, that 43.6 number increased to 51.6 that was allocated specifically for those services, which are listed right there. That's mobile crisis response teams, PAC teams, I-Court teams, ICSS, CHOICE, which is the housing program, community support services, supported employment, crisis stabilization units, and peer bridgers. And as I mentioned, Mr. Hutchins will kind of go into detail on some of those services. So ARPA funding, that's always a question. So we wanted to provide you an update on that. Senate Bill 2865 provides $86 million in funding, which goes through FY27. So that's allocated over the course of 4.5 years to meet the needs of Mississippians with behavioral health and IDD. So you can see $19.9 million is the funding for FY24. And that breaks down to 60 additional crisis stabilization beds, including 2 new units, 2 full 16-bed units, 1 for Region 9 and 1 for Region 8, based on the number of commitments that were occurring in those areas and the need for additional beds. The remaining of those 60 beds actually goes toward community mental health centers that maybe only had 8 beds or 12 beds to get them to 16. So just so you know, in case you don't, you can't go over 16 beds in a crisis stabilization unit. It's called the IMD exclusion. It's a federal rule, and you cannot have more than 16 beds in what is considered a crisis stabilization unit. So that is why, even if Region 8 and Region 9 had space to increase to, say, 24 beds in their location, they can't, based on this federal rule. So that's why there's 2 new units. Funding goes towards 988 and mobile crisis response teams, and Ms. Dorr is going to talk some more about that. Law enforcement training and court liaisons. We want to start 3 peer respite programs, which will be new in our state. Intensive community support services and adolescent offender programs for children and youth. We all know that since the pandemic, the mental health needs specifically for children and adolescents have increased drastically, so we need to have some focused support in that area. And then IDD crisis services and supports. Not only IDD crisis services and supports, but dual diagnosis. Individuals who have an intellectual and developmental disability and a serious mental illness, or people who have an intellectual and developmental disability that have behavioral challenges, making sure that we have crisis services for those individuals. The same Senate bill also has a paragraph for $18.5 million for community mental health centers for technology resources and other operating expenses. This was a request through the Office of the Mental Health Accessibility Coordinator, and I think it was directly more tied towards securing an EHR and making sure that data collection was consistent across all of the community mental health centers. So just briefly, I have a few slides, since this is the training for the commissioners on the required components of this. So state law, legislation that was passed several years ago, states that we are to provide an orientation training to all new commissioners. And that's a virtual training, and it walks you through many more components on the financial side, the reporting side. But then we also are supposed to conduct an annual training for all commissioners, and that's what this is today. So this training is going to be a little bit more focused on just an overview of the last year. The legislation also states that we have to provide to the legislature the individuals or the commissioners who do attend the training. And again, we know that can be difficult sometimes, which is why we are recording and offering a virtual option as well. Responsibilities of the commissioners. Some of this is also covered in your new commissioner training, but we wanted to just briefly run through these to just give you another overview. So the responsibility of the commissioner is you serve as the governing authority of the community mental health center. The commissioners make up the board that governs each community mental health center. You have the responsibility to adopt policies for your governing authority. You have a responsibility for the written documentation of an annual review, and these are the components that are required in that annual review. The annual budget, affiliation agreements, any changes in policies and procedures, submitting an annual operation plan to the Department of Mental Health, who certifies the community mental health centers, having a disaster plan, a process for meaningful individual and family involvement in service provision, and then completing an evaluation of the executive director each year. There's also a responsibility of the commissioners on maintaining written documentation. So you can see there's supposed to be public education activities. I think everybody in the room will agree there's still a lot of stigma attached to all three service areas. There's a lot of misconceptions. There's a lot of lack of awareness and education. And we talk a lot about the fact that you can have billboards up everywhere, but until you truly need the service, you're not looking at the billboard. And then when you need the service, most likely you or your family member is in a crisis situation and you're trying to navigate the system. So maybe are happening in your region and people know are key responsibilities. To present that region's budget and an overview of the service system. These are the sections in statute that directly apply to the regional commissions and the local mental health authorities. So if you haven't reviewed these, or maybe you just haven't reviewed these in a while, I encourage you to look through these sections, these code sections. Okay, I'm going to pass it off to Jake to go through some of the services that have been expanded and the service provision over the last year.
All right, we'll start with the commitment process, and this is the process where as individuals that need inpatient hospital care at one of our behavioral health programs have to go through the pre-eval screening through the community mental health center, and do a commitment process through the Chancery Clerk. We included the Mississippi Uniform Civil Commitment. Very small, so you probably won't be able to read that. But we also want to touch on the fact that in lieu of this, there can also be a physician order to take custody or do a physician's hold, involuntary hold for 72 hours. That allows the individual to be taken to a hospital or a crisis stabilization unit and treated for 72 hours with that doctor's orders. And then after the 72 hours, if the individual still needs to be committed, they can go through the commitment process. State-operated behavioral health programs. These are our state hospitals and specialized treatment facility. They provide inpatient services to individuals with mental illness. Mississippi State Hospital and also has a satellite program of specialized treatment facility, which is down on the Mississippi Gulf Coast in Lyman, right outside of Gulfport. It's a 36-bed PRTF, which is psychiatric residential treatment for adolescents. East Mississippi State Hospital is the oversight of the other two hospitals. East is located in Meridian and North Mississippi's in Tupelo. South Mississippi State Hospital is right outside of Hattiesburg and Purvis. Mississippi State Hospital provides several different services. They provide forensic services for individuals who are committed a crime. They provide acute psychiatric services. They have 100 beds, I believe, for acute psychiatric services, 25 beds for female substance use services. They also operate nursing homes. I'm sure I'm forgetting something, but lots of stuff going on in Mississippi State Hospital. East also provides nursing homes, but they provide substance use services for males, and that's 50 beds for males. North and South do not provide A&D services, but they are both small state hospitals, 50 beds each. And as I said, North and South, so we have them scattered throughout the state. East Mississippi also provides, as you see at the bottom there, transitional care. We have some Kemper County group homes, and we have a Central Mississippi residential facility, which is in Newton, Mississippi, that if individuals are ready to be discharged but just need a little bit more time, they can step down into those programs before they move back to the community. In FY24, we had 320 acute beds across the state. That was a 38% decrease in acute beds and 60% decrease in continued treatment beds. Some of the other information you can see in FY22, there was a 11-day waiting list, and in FY23, we had 5-day waiting list. So that has come down. Some of that was because of staffing with COVID. There were 1,965 admissions to our psychiatric hospitals in 23. That was a decrease of 11% compared to FY19. Average wait time for substance use admissions has decreased 54 days in FY22 to 24 days in FY23. State Hospital had approximately 31 days in FY23 and 16 days at East. Average across the state hospitals for readmission rates, you can see 30 days was only 3%, 180 days at 15%, and 365 days at 23.5%. Okay. I'll touch on this a little bit. I'm not responsible for the IDD programs. That's Craig Kitchell, who's over the Deputy Director for IDD services. But we offer IDD regional programs across the state, provide residential care to individuals. That's not only institutional care, but also community care for people living with an IDD. They are licensed intermediate care facilities. They offer diagnostic evaluations, determine eligibility for the IDD waiver. These programs include North Mississippi Regional Center, which is in Oxford, Mississippi, Hudspeth Regional Center, which is at Whitfield, right across the road from Mississippi State Hospital, Boswell Regional Center, which is, and also has a satellite program, Mississippi Adolescent Center, which is for adolescents, and it's in Brookhaven. Boswell's located in McGee, Mississippi, and Ellisville State School. And Ellisville State School is located in Jones County. in Ellisville, and then they have a satellite program, which is South Mississippi Regional Center, which is located in Long Beach, Mississippi. All right. Yep. Intensive community services. Go ahead. See what the programs of assertive community treatment. These are our PAC teams across the state. I know that in 2007, we took a group of community mental health centers out to Oklahoma, and we followed PAC teams for a long time out there and decided we wanted to bring them back to Mississippi. And at that point in time, we didn't have any PAC teams, and we currently now have 10 across the state. Intensive community outreach and recovery teams and intensive community support services. These programs are some form of these programs are available in every county across the state. It may not be a PAC team in every county. It may not be an I-Court team. It may just be an intensive community support specialist. But we have put grants and things in place to make sure that all the counties are covered across the state. All right. As I said, when I started years ago with the Department of Mental Health, there was probably no intention of having a PAC team. We now have 10. These are our most intensive community-based programs. So these are individuals that have multiple hospitalizations and need that level of care where people can come to them and wrap the services around them. It's a multidisciplinary team that serves people, as I said, who are not going to come to their appointments. Traditional treatment really doesn't work. So the PAC team's available to be nimble in the community and go out and treat these individuals where they're at. Okay. Intensive community outreach and recovery teams. I think this was a brainstorm session between Andrew Day, who used to work for the Department of Health, went to the Division of Medicaid, and now works with Don Brown and that group at Region 15. He, Brent, and I were looking at expanding PAC teams, but PAC teams are very expensive, and they're hard to find some of those professional people in some of the counties of the state. So we looked at other states and came up with intensive community outreach and recovery teams, which we call I-Court teams. In FY19, we piloted our first I-Court team, and that was in Region 2 in Oxford. It's a modification of the PAC team. PAC team has at least 10 staff on it. These are about 4 staff. They can cover more rural areas, and they've been very effective. Like I said, we expanded that in FY19, piloted, and then we expanded to 6 total teams in FY20. In FY21, we expanded those teams to 16 across the state. So we have 10 PAC teams, 16 I-Court teams. As I said, they're a smaller version of the PAC team, but they're able to cover more rural areas because of the less of the staffing requirements. Okay? Intensive community support services, they've been around for a long time. These are individuals that they have a smaller caseload than your traditional community support specialists, but they work with individuals who may be beginning a crisis to go into the hospital, or when they come back from the hospital to help them transition back to the community. We have, like I said, a lower staff to client ratio. In FY21, Regions 3, 6, 9, and 10 each received grants for 2 ICSS, and the former Region 11 received a grant for 4 additional ICSSs, which is this region here. Mississippi is providing funding for 35 ICSS across the state. We used to have 1 community mental ICSS with each community mental health center through the block grant, but we were able to receive grant funds to where we've expanded those to 35 across the state. Crisis stabilization units, they used to be operated by our state hospitals. The fact that they were operated by our state hospitals, they fell under the guidelines of you had to be committed to go there. So we wanted individuals to be able to go to a crisis stabilization unit voluntarily. We didn't want them to have to be committed to go there. So I think in 2009, we worked to transition the first CSU over to a community mental health center. We had a lot of negotiations with the legislators, and we piloted one to see if it would work. And after that, we were able to transition the other 5 that the state operated at that point in time over to the community mental health centers. As you can see now, we've expanded the number of CSUs to where there's at least one CSU located in each community mental health center. And as Wendy said, we're even expanding the numbers there. We have one in West Point operated by Region 7. Region 4 operates one in Corinth. Region 12 operates actually 2. They operate one in Laurel and one in Gulfport. Region 6 operates 2 because of their catchment area, Batesville and Cleveland. Of course, Dr. Crockett operates one in Jackson, and hopefully we're expanding to another one. Beth operates one in Goshen. Raquel operates Region 3 in Tupelo. Region 10 operates the one in Newton, and Dave Van and his group operate the one in Brookhaven, and has making plans to open another one in Rankin County. So we're excited about that. And we fought very hard and worked with as many people as we could to get the one open here in Natchez, and we're excited about the one being operated by Don and his group here in Natchez. So they've been very effective. Almost 89-90% diversion rate once we get individuals in the CSUs. We even offered some grants a couple years ago to enhance the level of security or staffing to where they could take more difficult people, and we're hoping all of that's going to pay off. But the crisis stabilization units, we're expanding. Like I said, we're looking for a location in DeSoto County to operate another one there. So the need is there, and we're expanding the bed capacity. All right. Mobile crisis response teams. These teams are available in every community mental health center, and they're available to all of the counties in that catchment area. They're staffed by master's level, bachelor's level peer support specialist or community support specialist. They can respond to wherever the individual is, having their crisis or need of assistance. They work very closely with law enforcement. We were actually a couple months ago, Katie, I don't know, I guess it was in the spring, we went up and filmed some videos in Oxford with Chief McCutcheons up there. He is mobile crisis fanatic, and his officers wanted to tell their stories about their experience with mobile crisis. So if y'all have great mobile crisis stories, we can load up and come out and share those stories. That way it gets the word out more and more. But it was funny to hear these law enforcement individuals that had gone through the CIT program and then had an interaction to where, we asked them, how did it work? And they were like, well, we just were there to lend assistance. We got out of the way and we let the mobile crisis people take care of it. So it's been very successful, and it's a very good service. Okay. Choice housing program is something. Oh, and to go back and just say one more thing about mobile crisis, but you don't have to go back. We started those in FY14, I believe, and that funding came out halfway through. We didn't get the funding until halfway through there. So the FY14 was about 6 months funding there. So Choice housing program is something that we started with the legislature and Mississippi Home Corps in 2015. Choice housing is for individuals that are in need of housing assistance. They have to meet one of the criteria of the Olmstead 3 priority categories. At one point in time, we had 2 providers in the state, Open Doors Coalition on the coast that only served the 3 counties on the coast, and then Mississippi United to End Homelessness was the provider for the other counties across the state, all the other counties except for the 3. We were notified in the spring that Mississippi United to End Homeless did not want to be part of this program anymore, so Open Doors said they would take this and go with it. They have almost doubled the number of individuals that were housed in vouchers. We had a presentation last week by Open Doors at our board meeting. They've almost doubled the number of individuals that are placed in choice housing vouchers across the state just in the time since July 1st, since they've taken it over. Had a very good, productive meeting with Mississippi Home Corps about changing some things, the length of time it took to get people vouchers. So This seems to be working well now. It was always a good design, but it just needed some tweaking. And I think with Open Doors being the housing provider across the state, we're going to see a lot more people housed with this. And the shorter times, I know when they come see Bo at State Hospital, sometimes the 30-day stay they're there or 45-day stay they're there. You know, they need a housing voucher, but by the time they discharge, we still didn't have a housing placement for them. So the voucher didn't help us out. So with the rapid increase of the amount of time for the housing, I think we're going to see a lot of people receive the housing and the assistance they need. Okay. Supportive employment is something else that we've started across the state. We started, I want to say, in 2015 or 16 with IPS sites. This was something that is a national model of placement for individuals. It was very successful, but we only had that in 4 community mental health center locations. After that, we expanded those grants to cover all the community mental health center locations. We have a partnership with the Mississippi Department of Rehab Services in those other counties that do not have IPS sites, to where our individuals, again, are not housing specialists, so we work with choice. Our therapists and case managers aren't employment specialists, so we work with Voc Rehab. We made the partnership with Voc Rehab to where y'all are the specialists in finding these jobs. If y'all will find the jobs, we will have the individuals that know how to treat the symptoms and the mental illness, wrap the services around them so they can stay on their job and maintain their employment. You know, supportive employment is a key to people's mental health. As you know, a place to have a choice voucher for a place to live is key to people's mental health. And, you know, homelessness is a stressor in it itself, you know. And, you know, one of the things we first did when we stood up in this meeting is we all said, this is where we work. You know, this is my name, this is where we work. So employment is vital. So if we can get the individual stabilized and wrap the services around them, we hope to break the cycle of these individuals coming back to the state hospitals, clogging up the chancery clerk's offices and tying up law enforcement, having to transport and things like that. So all these pieces fit together and, you know, enrich people's lives. Certified peer support specialist. Of all the stuff that I've talked about, this is the one that's probably closest to my heart. We started trying to do certified peer support specialist in 2004. We had a grant through SAMHSA, and we started hiring peers. We were able to hire peers at the Department of Mental Health, but since then, we have expanded this to where we actually have a certification that an individual can go through, just like our professional licensure credentials for therapists or substance use therapists or IDD therapists. People with lived experiences in recovery from substance use or mental health can go through our certification, and they can actually bill Medicaid if they work for the community mental health center for that service.
One of the primary goals of the Department of Mental Health, and will continue to be a primary goal, is to expand and support community-based services and supports. A lot of the services that you see on the screen, these did not exist 10, 15 years ago. And all of these services and supports are designed to help prevent unnecessary hospitalizations to one of our state-operated programs. We want people to live and to thrive in their communities and to not have to go to a state hospital bed to receive treatment only because the services and support don't exist in their communities. We want those beds available and reserved for the people who need that highest level of care. Jake talked about these intensive community support services that are now available in all counties. And you can see from these slides that there were 796 people that were served throughout the state by a PACT team. And again, the PACT teams, those are the most intense because of the staff composition. A PACT team is staffed with a psychiatrist or a psychiatric nurse practitioner, 2 registered nurses, a team leader, a master's level mental health therapist, a substance abuse specialist, an employment specialist, and a certified peer support specialist. So there are 10 of these teams throughout the state. They are around $600,000 per team. Those are funded by a grant by the Department of Mental Health. And they're only 7% readmitted to a state hospital that was served by PAC, or that's 54 people. I-Court, again, is another intensive community support service where they're going and meeting the people in the community. The staff composition of this is not quite as intense. That's why you'll see these more rural areas or in areas of the state where staffing challenges are more prevalent. And I-Court teams, they serve 638 people by the 16 teams, and that was 8% readmitted to the state hospital. The 35 ICSS teams throughout the state served 781 people, and then another 14,472 people were served in community support services. Supported employment that was mentioned earlier, 291 people were employed during the last fiscal year, and that's 708 that were served. Through the Choice Housing Program, we had 236 people that were served through Choice, and then another 282 in supervised and supported living. For the mobile crisis response teams, we got about 10,000 calls directly to those mobile crisis lines. And of about those 10,000 calls, there were 2,100 reported face-to-face responses where those teams went out in the community to meet people in crisis. There were 3,402 admissions to the CSUs, and that's a 92% diversion rate from a higher level of care. And 138 people served in the Navigate program. It's for people with that first episode psychosis, and that's 66% increase of people served from the previous fiscal year that began in 22. All right. Highlights from addiction services. During the last fiscal year, State Hospital moved its male treatment beds to East Mississippi State Hospital and now serves only women. So Mississippi State Hospital has 35 beds for females, and that can serve a female from any part of the state. And then East Mississippi State Hospital now has, and I said that backwards, State Hospital has 25. East Mississippi State Hospital has 35 beds for males, and they serve males from any part of the state. It's part of our budget request to the legislature this year to get additional funding to open more beds at East to bring that number to 50. But right now we have 25 beds at State Hospital for females and 35 for males at East. State Hospital served 225 people in their unit, and East Mississippi State Hospital served 381, and that's a total of 606 people served. We also have a diversion program. We have a staff member at the Department of Mental Health that works with the community mental health centers and our state-operated programs to see when people are court committed to one of our substance use disorder programs, could that person be served in the community? And through that program, we diverted 180 people from one of the SUD units to community treatment. We had 4,369 people served in community residential treatment. There are 624 community-based beds throughout the state for that treatment. Of those numbers served, we've also touched some priority populations defined by SAMHSA, which is the Federal Substance Abuse and Mental Health Administration agency. 890 were intravenous drug users, 101 pregnant women, and 93 women with dependent children. In addition, 675 people were served through the medication-assisted treatment program. Department of Mental Health also distributes Narcan to first responders and then community providers like the community mental health centers. In the last fiscal year, we distributed over 6,000 doses of Narcan free of charge to the community. We also provide training to law enforcement officers and to schools and also to community providers on how to use that Narcan and to realize the signs and symptoms of an opioid fentanyl overdose. We've also continued our CROP initiative. That's the Congregational Recovery Outreach Program. We have 3 congregations in Hinds County. It is faith-based, and they partner in various community health events. They receive training to educate mental health and recognize signs and symptoms within their communities, substance use disorder, and referral service. 83% of the surveyed trainees have said they are now more comfortable discussing mental health issues and if needed, recommending those services. Crisis services remains also a huge focus here in the state and in the nation, and we'll talk more about that. We're talking about 988. Crisis services are needed as we build the system out to make sure everything is available in the community when a person is in crisis, and that the coordination of those services works seamlessly. In our crisis services, we have 180 beds available in crisis stabilization units with a diversion rate of 92%. We had talked about the calls and contacts to mobile crisis. In addition to that, we had 13,549 calls that were answered by a Mississippi counselor in Mississippi by 988. Our state maintains one of the highest in-state answer rates, meaning if you call from a Mississippi area code, you're going to be spoken with a Mississippi-based counselor, and then the other percent would roll over to a national backup center. This is important because the Mississippi counselors know how to connect you to Mississippi services and supports. This is also an increase of 20% over the previous fiscal year, and we expect that number to climb each and every year as more promotion goes toward 988. We are currently working with Communicare and in discussion with Region 9 about follow-up protocols, and we'd like to bring this to all of the community mental health centers. This pilot is working that if someone calls 988 from one of Communicare's counties in their catchment area, and they consent to having a follow-up call by 988, they'll call and say, would you like to be connected with your local community mental health center? And if that individual says yes, then a member of Communicare's team will call them back within 24 hours to connect them with care. This is something we are working to bring throughout the state. Our next highlights are from Children and Youth Services. We talked about Navigate. It assists Mississippians 15 to 30 years of age who have experienced their first episode of psychosis. We had 138 served and 88 maintained in their homes. Wraparound facilitation, it's family and youth guided, provides those intensive services to allow children and youth to remain in their homes and community. Served 1,576, and 24 of those needed a higher level of care. Juvenile outreach programs, these improve behavioral and emotional symptoms and to prevent future contacts between youth and the youth courts. There were 1,514 served with 76% in continued treatment. And we see a couple of the other services in this section, youth and young adult peer support specialists. We have those for younger people. Intensive community support, which is coordination of appropriate services and the provision of constant and ongoing support as needed. And then early intervention and training, which includes mental health first aid, some of our suicide prevention efforts, and a lot of social emotional learning pilots in Mississippi schools. And then the last of our highlights are from other various areas throughout the Department of Mental Health. Our Division of Certification provided technical assistance to 188 people at certified providers. We continue our ongoing meetings each year with chancery judges and clerks and in the community to explain the commitment process law and talk about the resources that are available in the community. The Division of Place provided 233 exams during the past year. There were 164 full certifications granted and 131 place credentials renewed. As of June 30th, 2023, we have 3,392 active credentials in our state. And then more than 35,000 users of our DMH website had access, and then we saw more than 28,000 of our Mental Health Mississippi website, which is a site, although it's run by the Department of Mental Health, it doesn't look associated with the Department of Mental Health for people seeking that mental health information throughout the state. All right, 988 that we talked about earlier with crisis services, we spoke a lot of this last year. It continues to be a huge initiative with ongoing connection and pieces added to it each year. We just received a third grant from SAMHSA to continue expanding the coordination efforts between mobile crisis response teams and the crisis stabilization units, as well as staffing at our 988 centers. This 988 line went live in July of 2022. It used to be the 1-800 National Suicide Prevention Lifeline. It changed to this 3-digit number, and it is now not only suicide prevention, but behavioral health crisis. The vision and the goal of this line is to serve as an alternative to 911 for behavioral health crises. SAMHSA doesn't like it when we call it 911, but I feel it's important to explain what this vision is. This is served to be just as well known. The difference between 911 and that 988 is that 988 is the resource in most instances. You're being connected to a counselor versus 911 is the dispatching of resources. All right. This is being built on SAMHSA's national guidelines for behavioral health crisis care that we talked to. And it's a basic premise, but you have someone to talk to, someone to respond, and somewhere to go. You call 988, you're in crisis. You might have your crisis resolved on the phone. And we can go ahead and go to the next slide, Stephanie, where it shows that 80% of the crises are responded to on the phone just by talking to a trained counselor. And that's where it goes into 988 is the resource. Someone to respond. 70% of the calls that need someone to go and visit with them face to face by a behavioral health professional, those are then resolved in the field. Then of those that cannot be resolved for the field, you have the somewhere to go when you need additional help. And those are the crisis stabilization units throughout the state. Peer respite centers, diversion centers, just connection to resources sometimes. These crisis facilities have shown that 65% can be discharged successfully to the community, and then 85% remain stable with that follow-up care and continuing the cycle of services where you have prevention, you have crisis, and you have follow-up care so that people can remain in their communities. All right. Moving on to some legislation that passed last year, House Bill 1222. This is in effect now. This was called the Collaborative Response to Mental Health Act, and it touched a lot of little pieces throughout the state to have a collaborative response to solving some of the issues that we see. It aims to provide assistance both by providing training for law enforcement, that's a big piece, and then also helping to expand programs that work to divert individuals from inpatient stays at state hospitals into community services near them. You can see some of the provisions of this law as it requires law enforcement training, including mental health first aid and crisis intervention team training. So for mental health first aid for public safety, this is a training that every law enforcement officer in the state will need to receive. We have 8 years to do it. We actually have our first class coming up for Train the Trainers. We received some funding with this legislation, limited amount, to start these Train the Trainer classes, and then we'll continue expanding that throughout the state to make sure that everyone can get trained. And then crisis intervention team training. This law requires that a CIT trained officer, or if it's a smaller agency, they can partner with another county to have a CIT trained officer on staff. Increased utilization of court liaisons, and court liaisons again work to divert people from the state hospitals when that's acceptable to receive the treatment in the community. We'll now fund 33 of those. Also has some required reporting elements of the chancery clerks. And with the required reporting elements, we've opened up our bed registry so that chancery clerks can see what CSU beds are available throughout the state. It applied term limits to our Board of Mental Health, required yearly annual training of CMH commissioners and new commissioner training that was reiterated in this law. Adds a chancery clerk or sheriff to serve as a non-voting liaison to the commission. And then it also required law enforcement to transport to an appropriate healthcare facility at the request of a CIT team in mobile crisis. If they're out there working with someone in crisis, law enforcement can now transport at the request of those teams. Another piece of legislation that passed last year that's important is House Bill 231. So you can see in 2022, there were enough opioids dispensed in the state that 77% of our population could have a prescription. More than 358 Mississippians died from an opioid overdose in 2022, together with countless others that we know that are affected. The good news is this is a decrease, but still too many. There are 491 deaths in 2021. This legislation was authored by Representative Sam Creekmore, and it's working to push fentanyl education into the schools and into the communities. So this legislation requires the Department of Mental Health to create a task force, which we have. It is comprised of advocates, community mental health center employees, medical practitioners, Department of Education, nurses. We have a really wide array of professions and backgrounds of people who are serving on this task force, all with the goal of creating or selecting, is probably the right term, a curriculum that can go into the schools and provide this fentanyl education to our youth and young people. And it's more than a just say no. It'll go in and it's going to teach about fentanyl and awareness and harm reduction to help get that education into the schools before they become one of the statistics. Along with it, there's a media campaign aspect, educational materials and dissemination, community partnerships. We also have to have a review to make sure it's working. We also received a limited amount of funding for this, so we're going to pilot it in two to three schools within the year. Let's see, one more. It's hard to talk about all of these services and our desire to expand support without talking about the workforce. We know there's a lack of behavioral health professionals in this state and in this nation, and that impacts everything that we're talking about. So just want to end with a couple of key findings from the National Council. They performed a study on behavioral health workforce, and we thought these were important to highlight. That the vast majority, which is 83% that responded, of the nation's behavioral health workforce believes that without public policy changes, provider organizations won't be able to meet the need or the demand of mental health or substance use treatment or care. Our behavioral health workforce doesn't feel there's enough of them to meet this demand. Around 9 in 10 behavioral health workers are concerned about the ability for those not currently receiving care to gain access to care, because that's 90%, and the ability to provide care in the event of another health crisis in the future. Nearly 2 in 3 reported increased client caseload, and more than 7 in 10 reported increased client severity since COVID-19 pandemic. And I've heard that, and I know each of you probably have too in your communities or seen it. Nearly half of the behavioral health workers say the impacts of workforce shortages have caused them to consider other employment options. More than 4 in 5 behavioral health workers worry that workforce shortages in the mental health and substance use industry will negatively impact society as a whole. And a third of the workforce reported spending most of their time on administrative tasks, with 68% of those who provide care to patients saying the amount of time spent on administrative tasks take away from the time they could be directly supporting clients. So just ending on that, not as a low, but I think it's important to know when we're talking about all of these services and to keep our focus on the workforce when we're thinking of new initiatives and supports and the system in our state.
We're going to wrap up with just a couple more slides. This is something that if you don't have much information on, I encourage you to talk to your community mental health center about, because it's relatively new. So CCBHCs are certified community behavioral health clinics. You can see here a map of the nation, and you can see we're kind of a dark green. We received a CCBHC planning grant earlier this year. We were one of 15 states that received it. This is to look at a different way to structure a community mental health center through the certification to become a CCBHC. If you're staying for the rest of the conference, there's several presentations on CCBHC over the next couple days. If you can, I encourage you to sit in on one of those. If you can't, like I said, talk to your community mental health center about what their role is. Some CMHCs have individual grants. 2 CMHCs, Beth's, Region 14 and Region 6, are part of the state planning grant. But you can see it's a movement throughout the nation. The red states have an established CCBHC model already through the Medicaid demonstration grants. Let's see, that's what, a darker blue. They received planning grants in 2016. The greens, 2023, that's us. You can see there's only a few states that have no CCBHC action as of yet. So you can tell that it is definitely a movement across the nation. And go to the next slide. So this is why, and this is the value that it would bring to our state. It improves access to and delivery of community-based services. It addresses gaps or barriers to care. It establishes sustainable funding for additional investment to be shifted towards quality evidence-based services. It offers more competitive wages because of the cost reimbursement model. It holds community mental health centers accountable for quality outcomes. And most importantly, to me, it engages stakeholders and consumers in the creation of and the development of the model. CCBHCs have to serve somebody regardless of their insurance status or their ability to pay. They have to provide 24/7 services and crisis services. That's where you come up with the quality outcomes. The requirements on a federal level for a CCBHC are very high, but I think it's something that we can aim towards to get in our state to provide that better service and better access to people. So the last slide I want to go over is some future goals. These are some things that we're looking at in the current fiscal year that just started in July and in the next fiscal year. However, the majority of these goals cannot be accomplished without the community mental health centers and the partnerships. And these goals can't be accomplished without a behavioral health workforce. So it goes back to Ms. Store's earlier slide. We have to have a workforce to be able to accomplish. But over the next 2 years, we want to increase that crisis stabilization bed availability, get those additional 60 beds in the community that we know are needed. That coordination with 988 and improving and strengthening that as we move forward. Expanding access to addiction treatment services. Again, we're seeing the substance use disorder numbers on the rise across the nation and in Mississippi. Making sure that we have crisis services for people who have an intellectual or developmental disability. Increasing that access to intensive crisis services for children and youth. Utilizing court and hospital liaisons for diversion from state hospitals. I think we have a couple chancery clerks in the room. Being able to have a court liaison in your area based on the number of commitments is how we're doing it now because we have funding for 33. But having that court liaison or that hospital liaison that can work with someone when they come in to try to connect them with a service to keep them in the community and not have to go through the civil commitment process. Like Ms. Dorr said earlier, we have to have a continuum of care. We need state hospital beds. But we need those reserved for individuals who truly need that level of care. So if we can divert, we want to focus on being able to divert individuals. Expanding home and community-based services to prevent institutionalization for people with IDD. I know we didn't spend that much time on the IDD side today, but I just want you to know the IDD home and community-based waiver, which helps individuals stay in the community and not have to be in a regional program, which the state operates, or even an ICF level of care in the privates. There are about 2,700 people that are receiving services on the waiver. There's 2,800 people on the wait list. There are now more people waiting than there are receiving the services. We have to address this. It's a significant portion of our agency's budget request for this upcoming year. Statewide outreach campaign for service availability. When we talked a few minutes ago about CCBHC, there was a statewide survey done as part of our CCBHC planning grant. And I think, I'm trying to remember, it was like 68% of people are not aware of the services that are available. Again, I think that goes back to until you need the service, you're not thinking about the service, and then when you need it, many times you're in a crisis situation. But making sure that people in the community know what services are out there. Expanding mental health law enforcement training. Law enforcement, you're oftentimes the first responder for a mental health crisis, and that's not what we want. We want that mobile crisis response team to be able to provide that connection, but we know law enforcement's going to have a role as well, and we want to make sure that you're equipped with the information that you need to be able to respond through the mental health first aid training and crisis intervention team training. Developing 3 peer respite programs. That goes back to those certified peer support specialists and the value that they bring. And many times somebody can be in a mental health crisis and they need someone just to talk to. And certified peer support specialists are key to that. And if they have somewhere they can go for about 24 hours for respite and connect with that CPSS, I think we're going to see a big difference with these 3 pilot programs. And I think there's only about, Brent, like 40 in the nation? There's only 40 peer support respite programs in the nation, and we want to add 3 more to that number. And then building an 83-bed forensic service unit at Mississippi State Hospital. This is a major goal. So the state has been limited to 35 beds for many years for forensic services. Oftentimes when you hear stories about people waiting in jail, there's sometimes a confusion. There's some of those individuals are waiting for civil commitment in a bed at State Hospital, but many are waiting for forensic evaluation or competency restoration. With 35 beds, the state has been extremely limited because those beds were also for individuals who'd been declared not guilty by reason of insanity. We did not have enough capacity. So with funding, there's been a complete renovation of a building at State Hospital, and hopefully next fall, we're gonna have an 83-bed forensic unit. So we'll be able to see some relief in that area as well. So these are our future goals. But again, we cannot do these goals without our partnerships, without other providers, without the counties, without law enforcement, without the chancery clerks. Hopefully you can see through this training today your role and how that fits in to the state system and how it's going to take all of us working together to make it better. We highlighted a lot of progress and a lot of individuals that were served. Please know that we know where there's gaps in services. And we know that there are more individuals out there who need services than who are receiving services. And we know there's areas in the state in particular with higher numbers of individuals who are being committed to the state hospital, and we know we have to have focus on those areas as well. So while we're proud of all of the progress that's been made over the last year by providers and the Department of Mental Health, we also know that we've got areas that we need to address. And I think we can do that if we're all working together and on the same page.